Hi, this is Dr. Bhargava, and in this short video, I have several interesting cases to share with you all. This is our first patient, a young female who presented with chest pain and shortness of breath for about a month. And so an acute pulmonary embolism was suspected and a CTPE protocol was performed. So here we can see that there is good opacification of the pulmonary artery, the left-sided branches, but on the right-sided branch approaching the division, we see a large filling defect, and this was reported a clot or acute pulmonary embolism and persisted after the initial treatment. And so because there was a long history of patient symptoms, a tumor was suspected and an FDG PET-CT was performed. Here we have some changes in the lungs from a developing infarct in the right upper lobe. So the patient underwent a whole body FDG PET-CT, and we will start by reviewing the rotating image. We see this focus of intense uptake in the chest. This focus corresponds to the tumor that I showed you before from a contrast enhanced CT, seen right here. And we don't see the tumor as well on this low dose CT without contrast that comes with FDG or a whole body PET-CT. We do see faint inflammatory uptake from the right upper lobe lung infarct. And so what could this be? This turned out to be a very rare tumor arising from the pulmonary artery intima called a pulmonary artery sarcoma, and the patient underwent a right-sided pneumonectomy to remove the tumor. Here is an interesting article that talks about the utility of FDG PET-CT in patients with pulmonary artery sarcoma. And so because this is a rare tumor, if there is uptake of FDG, then we can more confidently diagnose a tumor. And if there is a clot from an acute pulmonary embolism, that would not show any FDG uptake, and it would be photopenic or ametabolic on FDG PET. This is our second patient. They presented with meningiomas, and we performed a dotatate PET-CT to evaluate multiple meningiomas in their head. So here's the rotating image, and on the rotating image we find physiologic uptake in the pituitary and some other foci of increased uptake in the head, which suggest meningiomas. The rest of the whole body shows physiologic distribution with uptake in the adrenals, uptake in the spleen more intense in the liver, and excretion from the kidneys into the urinary bladder. So on the cross-sectional images, this is one of the meningiomas. Here's the second one. This is a third one. And this could be recurrent because we see signs of a craniotomy here. And we don't want to confuse this uptake in the sella turcica in the pituitary, which is physiologic, with a meningioma. And so we know meningiomas take up gallium-68 labeled dotatate. And here is an article talking about peptide receptor radionuclide therapy in advanced refractory meningiomas using high-dose lutetium-177 dotatate. This is our next patient. Patient presented with history of prostate cancer. They've had prostatectomy, and we performed a PSMA PET-CT to look for recurrent or metastatic disease. As usual, we will start by reviewing the rotating image. We see physiologic distribution in the lacrimals, the salivary glands, uptake in the liver, more intense than the spleen, excretion from the kidneys into the urinary bladder. There is some asymmetry right here. There is not as much uptake and excretion from the right kidney compared to the left. A Foley catheter is in place, and on cross-sectional images, we see the bulb of the Foley catheter. We see post-surgical changes from the prostatectomy. There is no evidence of focal uptake to suggest local recurrence or metastatic disease in the pelvic nodes, bones, or any other soft tissues. The interesting finding here, and this is a finding that was missed by the reading physician, a nuclear medicine physician, and this is a good example of the findings that may be missed by nuclear medicine trained only physicians with no or not much radiology background. And so I gave you a hint about this finding before. On the cross-sectional images, the right kidney shows hydronephrosis, and because of that there is less uptake and excretion of PSMA, and more inferiorly there is an obstructing stone. So this is an acute finding of a stone obstructing in the ureter, leading to hydronephrosis, and should be reported, and not just reported, but you need to call the referring physician because something needs to be done about this. Otherwise, this hydronephrosis will worsen and the kidney will eventually die and will have no function. And so this was shared by a colleague from another institution. And like I said before, these are the kinds of findings that may be missed by physicians who are trained only in nuclear medicine and not in radiology. So be aware, and if you are one of them, then learn from such misses from other people. And so the stone is also seen here on the fused image. And here is a article on prostate-specific membrane antigen PET, clinical utility in prostate cancer, normal patterns, pearls, and pitfalls. So a good article from Radiographics. Thank you for watching.